beautiful. I have this.
Okay, let's call to order the meeting of the Homelessness Committee, and if we could begin with introductions, and if we could start with you, Nancy. You're on.
Okay, thank you.
For introductions.
Nancy Burke with the Mayor's Office.
Zach Burgess, Institute for Community Alliances.
Don Weddleton. Tim Steele.
Pete Peterson. Dick Tranning.
Forrest Dunbar. Bill Evans.
Sierra Smith.
And in our audience,
Lauren Maxwell, Channel 11. I'm Susan Carlisle from the Social Work Department at UAA.
Lisa Aquino from Catholic Social Services. Beth Wilson with the Division of Behavioral Health. Karma Reed with HUD. Colleen Bickford with HUD.
Lisa Caldera with the Transition Center.
Michael Baldwin with the Alaska Mental Health Trust Authority.
Connie Ernst, MOA Risk Manager.
Alfred E. Newman with Mad Magazine. Here we're talking on progress of fighting homelessness.
that works. Okay, now back to our agenda. Any changes or suggestions or amendments to the agenda? Seeing none. The first issue on our agenda is an initiative update, and turn it over to Nancy.
Thank you. So this is the placeholder that we'd like to keep on the agenda. I feel like I should put it over there. For the committee, as we build out a dashboard that will give us those numbers that we've begun to track with our partners in the community, how many people were housed, how that looks will be a little bit more spiffy than what you have before you. But right now, what's exciting is we do have our HMIS database producing these reports for us. And so Zach is here from the Institute for Community Alliances. And he's able to walk us through this report, which reflects the period of January 1 through March 14.
Cool. So on the report, we've broken it down by where people are exiting when they exit a program, or a program here in Anchorage. And on the page that says destination by household type and length of stay, all leavers who stayed more than 90 days, the people who exited during that time frame between January 1st and March 14th, there was 30 people total. I'll break it down by households here in a second. But 30 people total that exited to a permanent destination. And then on the other side of people who stayed 90 days or less, there was 75 people who exited to a permanent situation in that same time frame. And it gets broken down by whether they housed themselves permanently, housed themselves permanently, or if they received monetary assistance, or if they went into a doubled up situation, which would be the bottom two of the shaded portion, the living with family or living with friends. And so you can see that there is 5 people that are listed as living with family. That means they went back. 5 on one side and 16 on the other. That means they went back into, or they went into a doubled up situation permanently. That's indefinite. And then there is rental. Another highlight would be rental by client with, I'll just start at the top and work down. Owned by client, no ongoing subsidy, and that's on both sides. And there was one client, one person. Owned by client with ongoing subsidy, that would be some sort of subsidy was given to the client, and there was 4. You got those up. Rental by client, no ongoing subsidy. That means there was 5 people, and we can break that down by family here in just a second, but 5 people who stayed 90 days or more, and then there was 38 people who got a rental but did not have monetary assistance. It talks about the VASH subsidies there as well. There's 2 people total. Rental by client with other ongoing subsidy. This would be a subsidy that is not directly tracked in HMIS, but it was noted that they got some sort of a subsidy at some point. So this we produce monthly and deliver to the coalition, Anchorage Coalition to End Homelessness, and Nancy has asked that we produce it for this committee as well. And One question we get whenever we produce these results, we get asked about the different populations, such as individuals and families. And there were, based on this data, there was 23 families that were permanently housed since January 1 in the Anchorage system, that people that enter into the system. There were probably people that were permanently housed that do not use the information system, so we don't have those numbers available. So of those 23 families, 4 went back into a doubled up situation. 9 families got their own place without monetary assistance, and 10 families were permanently housed with monetary assistance. Any questions?
Mr. Dunbar.
I'm sorry. What is the data on the other side of this paper?
Oh yeah. So if you read the title here, it says all leavers, and when it says leavers, that's people that exited from homelessness or from a program. So all leavers who stayed more than 90 days, and then the other side is all leavers who stayed 90 days or less.
Oh, I see.
Yeah, that's a little confusing. We can break it. We can aggregate it further if that's needed.
Mr. Peterson, then Mr. Weldon.
Thank you, Mr. Chairman. And I'm not catching the PSH abbreviation.
Oh, I'm sorry. Permanent supportive housing.
Okay, thank you.
Mr. Weldon.
So what would other ongoing subsidy?
There are certain funding streams that enter into HMIS, into the Alaska Homeless Management Information System, and there are some that do not. And so if a case manager noticed that this person has said that they received a subsidy that was not tracked in HMIS, they would note that in the system. That's how. Let's see. Federal funding is always tracked in the system. There are some state programs that are tracked. There is some prevention dollars that are tracked in the system. An example would be if a church helped with rental assistance, that's not tracked in the system. There are, there's probably so many of them.
But there's a lot. There's so many.
Mm-hmm. So that's data that we don't know what exactly the subsidies are coming from. We could drill down and ask each of the individual case managers, what did the client tell you they got? Where did they get the money? But yes.
Is it are those families that were rapidly rehoused with properties?
There are some of them were probably. I don't have that.
No, that's okay, but that's an important pot of money that people. So a part of that budget pot is paid to the community. There's a fund to rapidly rehouse families, and that would be that group of under 90.
Mm-hmm.
I know we didn't have good data previously, which is a big effort that we've been making. But is there any sense that you get among the entire community as to whether these numbers reflect a faster pace than previously? Are we getting people into shelter more quickly? I know we don't have the exact numbers, but
When you say into shelter, you mean into emergency shelter?
or actually being leavers more quickly.
I will also let Lisa chime in on this. I feel like we have always had a sense of how it's going, but not actual numbers for us. I feel that one of the things with those entities sitting around for the adult system and now the family system starting to coordinate every other week, those groups sitting around the table each week have certainly made it go faster because we're just right on top of openings. Whereas before, it really fell to the agencies to go out and try to find individuals qualified for their units. So that has helped us go faster. It's also created some more challenge and confusion because now we have to figure out how to coordinate it all. So that's added a layer of organization for us. But I think that we're seeing people, we're more efficient at getting people in. But one of the great things about this tracking people who are in the system less than 90 days and then more than 90 days is that helps us know how many people are, we'll know how many are staying beyond 90 days, which is somewhat of a threshold that we'll be paying attention to in the future. We'd like people to move out within that window, but we'll be able to pay attention to those that are not.
Mr. Welton and then Mr. Dunbar.
Right, so looking at this, the vast majority of people who were in the system, which I might ask you to refine, I guess, and then most just went away. They maybe got in the woods or moved out, we don't know. But the vast majority didn't want out. Interpret this aloud.
Well,
I would.
That's us. Right, so that's the shelter. And all that means is that our process, when we check someone in every night, you enter Brother Francis Shelter and you exit the next day. So we're not necessarily doing an exit interview to find out where you're headed that next morning. So that's why it's not a permanent destination, but through case management is where you would get the upward grade box. So a lot of that 11 or the 1,080 or so come back to shelter the following night, which is ongoing.
So it could be the same people recycling.
Yes,
So it's
and those
more
combination.
attractive check-ins than people.
Those are bed nights rather than individuals. And we may, if we're in our dashboard, we'll be able to clarify that. So we'll have these numbers feed into how many people were housed before 90 days, how many after 90 days, and then the shelter, the bed nights, we'll be able to track as well.
Lisa, you have a comment?
Just a tiny bit more detail, just adding on to what Lisa Caldera said. So just to say that, Catholic Social Services in the past year, we've really been focusing on getting people into permanent housing and measuring that. We've always done that, but to measure that. So I would estimate that through our services, we are getting about 40 people, a little bit more, into housing each month through our services. So, and to give you that's kind of around, and that's community-wide. That's through both of our shelters and in the community work that we're doing. But I think it's important to understand what Lisa's saying too. So we don't have enough case management at Brother Francis Shelter so that every single person who's coming in the door is seeing a case manager. But we're working on always trying to connect every individual with case management. That's what
Mr. Dunbar.
Yes, I'm just, I think, like John, trying to understand the data a little bit better. So this, you said 1,082 is not the number of people, that's the number of bed nights. Over what length of period? In one night?
No, so that's number of individuals who would have had an entry and an exit attributed to most likely emergency shelter. So right now you've got Brother Francis Shelter, Downtown Soup Kitchen, and Beans Cafe feed into HMIS with entries and exits. So every time somebody comes, you're gonna have an entry, and then depending on the process, that exit could be the following day, or it could be at the end of someone's period of time that they're staying. So this is saying that you probably had 1,082 people have an exit, which would then probably attribute to also an entry during this period of time.
But if somebody,
at least one exit.
so if some, and this is during a 90-day period?
This is from January 1 to March 14.
Okay. So, which is like 75 days. Okay, yeah. So, okay. But does that mean if one person came in January, then exited, then came back in March, are they counted as one person here or two?
It's one.
It's one. So you can't tell that. So this is
Unduplicated.
This is 1,170 people in Anchorage that experience some form of homelessness, even though it's brief homelessness.
Mm-hmm.
Okay. And then I guess my follow-up question to that is, so we know that there are, 105 people that are leaving, right? Left during this period, 30 that were long-term and 75 that were shorter than that, right? Do we have measurements of, so 105 left, do we have a measurement of how many we gained? And what the net is?
People entering the system, we can get that, but I don't have that available at this moment.
So I understand this is all kind of new, and so we're still getting this data, but ultimately that is what the question we're asking, right? Is how many are we netting every month or every, whatever time frame is?
Yeah, well, we have data back. Data before June of 2015 is very sketchy, but I mean, we could pull that data. We just haven't been asked for it yet.
Okay. Well, I mean, we need more than just 1 or 2 years of data. We need to see how this compares to, not just how it compared to last month, but how did this February compare to last February and the February before that, right? To know if we're having an impact or not. Okay, thank you.
Any other questions on this sheet?
So just one other note that as we look at entrance into the system, exits from the system, length of stay in the system, going back to this chart where we think about people in terms of low, mid, or high needs, we then can, as Lisa said, there's not enough case managers to work with everyone in the system, but how many people need them? How many of those folks are low need folks just hitting shelter, will get right back on their feet and back out? How many people do we need to allocate case management resources to, and at what level? So the folks in the mid category are going to need a lighter touch on case management than our high-end folks. And these numbers, as we get this dashboard to the place where we can really just, it becomes a formula, that's what we like to, that's where we're heading with it.
Is that it for the initiative update?
One other point about some of the pieces that are also helping surround this, and part of the thing that we're all getting on top of in our minds is that there is core data that HUD requires us to have in the HMIS system, but we are really trying hard to build out the system so that it captures other community data, so that we don't have parallel systems popping up to track the same types of information. And so as we move forward, this dashboard will continue to be clarified. How many people are participating in community programs? How many people in our core HMIS programs that have that required data element? And how do we make sure that we capture everyone so we're getting one picture and it's complete, or it's more complete as we move forward in the years and begin to see how we're doing. So that's, there's a team of people around this, the system administrator, Christy, that's come and presented to us, and the 2 transition coordinators are helping us figure out how we organize people into different areas of the data system so that we also don't have to keep multiple wait lists. And that's been much of the conversation for the past month, and very helpful for those of us who really hope to have it solidified into one place. So that's a little bit more about how that's working. Other than that?
Obviously, as you can see, the data that we're getting is critical to problem solving. What do you see as the biggest threats or potential threats to our ongoing process of getting this data and expanding it in the manner you just talked about? Are there things on the horizon that we need to be aware of to make sure don't have it?
In terms of the data collection?
Yeah, the whole process.
I think our biggest problem in the community is this one, that the HUD resources are fairly complete. They come with rental subsidy, they come with case management, and they come with ways to help people transition very in a long-term way. It's a robust program, and those programs typically serve people at our higher end of the continuum. But it's this mid part of the continuum where we have a hard time with data. We actually, frankly, have a hard time finding these people because they're not attached to case management services, and there is not enough at the shelter to go around. And so focusing, this is one of the reasons we wanted the social service coordinator in APD, because that's a place that we can have more frequent touch for those folks. But having what we call free-range case managers is one of the pinch points in our system. And that, I would say, that's our biggest barrier.
Thank you.
If I could also throw in one thing. One thing that I work with directly with the providers, training them on the system, helping them to use the system. And I think that buy-in from providers is probably a really big one. There's several agencies that, just either they come to meetings or they don't understand the process, and so having that higher level champion, to be in the system, like Lisa, is very much like, let's make this happen, and Lisa Calder at Brother Francis Shelter, let's make this happen. So that would be another barrier.
See any other questions?
Okay. That is our initiative report.
So let's move on to the Alaska Mental Health Trust Authority section.
Mike Baldwin from the Alaska Mental Health Trust Authority, from a longtime colleague of mine, here to present to us a place where our work in looking at the needs of the homeless in our community, one of those needs is access to substance use treatment. And it's the topic of some of the infrastructure development that's going on under the Mayor's initiative around homelessness. But it is one piece, our homeless piece is one piece of a larger system analysis and a larger system to help people access treatment in not only our community but across the state. And the Trust has taken the lead in trying to organize both an assessment and then working with communities on bringing assessment information to the local community to help increase access to services. That's all it.
Thank you, I'm done. Very good. As Nancy said, one of the key focuses of the Alaska Mental Health Trust is to improve systems of care for our beneficiaries, individuals with mental illness, substance use disorders, developmental disabilities, Alzheimer's disease and related dementias, traumatic brain injuries, and a few years ago now, probably 5 years ago, in some of the work that we were doing in working with the state, we were asking questions about what is the capacity of the behavioral health system in Alaska, and no one was able to really answer the question. I think recently at the national level we heard healthcare is complicated, and it's even more so at the behavioral health kind of level. For whatever the reason, it's just basic questions about the system were not able to be answered. How many people are being served? How many providers do we have? And so on. And so a team got together with the state Alaska Division of Behavioral Health, the Mental Health Trust, as well as some key partners, to figure out if we could start to answer some of these questions. And so the result of that was our behavioral health systems assessment, which we just wanted to know some basic information. And so some of the goals were really to, one, describe what is the behavioral health system in Alaska. In particular, what we were interested in is the publicly funded behavioral health system, because there is a range of private providers in the community, but the public system carries the responsibility for the majority of Alaskans. So we set about trying to describe what is the current publicly funded system, the tribal system and the non-tribal system around the state. We wanted to try and identify what the need is, how the system is being used, and what's the capacity of the system to meet that need. Simple questions, but very challenging to access. Actually, kind of got ahead of the slides, but that's good. The other piece is we wanted to see ultimately where the gaps are and where we can help advocate, and where folks can advocate for addressing gaps in the system. We'd hoped to kind of build this into kind of an ongoing monitoring kind of process at the statewide level, as well as have information that could go regional, because the state system is built up from all the regions. And so one of the final pieces of what we did. We have, besides the overarching report, we also have 10 behavioral health regions in the state. Just maybe too much in the weeds is the information that we were dealing with is protected healthcare information. And so some of the challenges we faced were, how do you describe who's using the system, how they're using the system, and still protect someone's privacy. And so one of the interesting challenges, federal law prevents, and I'm going to use giant air quotes here, information from being published to the public about protected healthcare information for communities less than 20,000. And so, as you can imagine, Alaska is very broad, and there are many communities and regions that have. So the State Division of Behavioral Health and the Trust worked together and we kind of created 10 regions. The Division of Behavioral Health really taking that lead. So we had the ability to access some information and put out some information. There's still some limitations to what we can put out, but I think we've got to get started. So today we'll talk a little bit about some of the high points of what came out of the Anchorage region area. We'll also talk about kind of prevalence, who's using the system, and then we'll touch briefly on a little bit of funding. Just for a little bit of backup, and again, you don't need to focus too much. There's a lot of data that we kind of went into this. Prevalence and risk factor data, we use national surveys where they actually surveyed Alaskans to get information from the National Survey on Drug Use and Health, the Youth Behavior Risk. We also use the Department of Labor's population and census information to kind of pull together prevalence. To address some of the service utilization system, this was also a large chunk and really about the confidentiality I was mentioning just a minute ago. We pulled information from the state's Medicaid Management Information System. There's a system called the AK AIMS, the Alaska Automated Information Management System, that the State Division of Behavioral Health tracks all clients in their system that state public health are being used. Electronic data interface, it's kind of a method of information being transmitted from providers to the state that aren't in their system. The State Psychiatric Institute, as well as kind of the information from the network of evaluation and designated evaluation and treatment hospitals across the state, which is kind of the step down below API, the Alaska Psychiatric Institute. It's the regional way of trying to address needs before they actually have to come into API. So in doing this, we encountered, I think it was somewhere around 6 million records in the course of this to try and sort through, and which is kind of it hadn't been done before, and so it was kind of intellectually in a geeky kind of way, kind of fun, but definitely hurt the brain a lot. And we also had a lot of stakeholder input and data, where we engaged with providers around the state, in the tribal health system, as well as the non-tribal health system. We looked at key informant interviews. We also spent some time looking at workforce capacity, which is a key piece of any kind of capacity. So in trying to describe the state behavioral health system, or any continuum of it, behavioral health is referring to mental and emotional being and choices and actions that affect wellness. This could be things that fall in here, include substance abuse and misuse, addiction, psychological distress, suicide, mental illness, kind of range. As I talk, I'll be kind of focusing on a little bit more on the serious mental illness and seriously mentally ill and substance use disorders, of course. And publicly funded through state Medicaid dollars and or grants from the state general fund. So to describe, part of describing the system, and you can't read this, but I can actually pass out a handout here a little bit. To look at any part of the system, you have to look at the forces that affect the system. And in the process of doing that, we kind of came up with a diagram from federal, state, and local policy systems. There are a wide range of factors that will impact any system of care. And over the course of the project, about a year and a half, we updated this chart multiple times because there were new developments. And since this was published last year, we basically probably need to redo this whole chart, especially with at the national level with the repeal of the Affordable Care Act and the new proposed American Health Care Act, and some of the ripples from that will change a lot of these forces. This is part of support that the system is complicated. So when we start to look at what's the need, what's the prevalence in Alaska, when we looked at adults, for adults in the system, at the time of this study, it was covering the years 2009 to 2013, and there were approximately 546,000 adults in Alaska. Well, through our results, we ended up finding that about 1 in 4 Alaskans had some sort of mental health or substance abuse related needs. Not too different from the national plan. So it seems bad up here, but we're actually kind of similar. When we look at kind of category breakdown in terms of needing treatment for drug or alcohol use in the past year, substance use disorders, about 11.5% of the adult population had some need for that treatment. So that equated to about 62,000, 63,000 folks. When we looked at mental illness, and this includes mild, moderate, and serious, so there are about 20% of Alaskans had some sort of need across that, which is about 105,000 people. When you broke down the mental illness category and looked at the severely mentally ill, it was about 4%, 3.9% of adults had some sort of significant mental illness. If you look at moderate, about the same, 4.5 thousand, about 23,000. When you looked at mild mental illness, so this is the category where it typically doesn't rise to the level where folks are probably seeking treatment, but that is out there. About 11%. Question? I'm sorry.
I guess I'm having a real hard time absorbing this, that 1 out of 4, a lot of us in this room are having serious mental problems.
It's actually higher in the Assembly.
But a lot of that is this past year mid-mental illness, and you're saying, I mean, how do you get that number? So it's people who had a couple bad days, and they just told you on the survey that, yeah, I had a sad day one day,
Great question. They're responding to surveys about how many days out of the last year or out of the last month they were experiencing some sort of mental health problem. And that's more on the mild mental illness.
What would that mean?
That could be someone having a bad day. They're mildly depressed. They had a relationship breakup. They had something go wrong at their presentation in the assembly. The seriousness it's not quite as chronic as some, for instance, the serious mental illness, which tends to be a lot of the homeless population, where it could be schizophrenia, something chronic and long-term. I'm not sure I'm getting to you.
I think I understand, but then I see this going to that big chart, or column on the left, estimated behavioral health need. I mean, everybody has a bad day, a bad day, but you rebound. I don't really have a behavioral health need. I just come into a rebound from a bad day for this family, and I'm good the next day. You move on. Is that really behavioral health need? Not really. It's just you're living life and things happen. But this makes it look like, oh, we got a crisis management for us. Mental health. So we can do something like. But most of that's just trivial. It's just you live life and rebound.
There's definitely kind of that level, and that's where that mild category is, and those tend to be folks that are having something that's kind of a little more transient. It's just still identified as a need. They're really more focused within the publicly funded system. It tends to be kind of more of the substance use and moderate to severe mental illness.
I get that, but I guess maybe now I'm more surprised that 85% of us never have a bad day. I want to meet those people.
Well, and that's a great thing. Comment about survey methodology, and as they were interviewing the Alaskans, the sample of Alaskans that they interviewed, they may not have been willing to admit an experience of some sort of issue or substance. There's within survey methodology, it's called social desirability, not wanting to present in a negative way.
Mr. Steele and Mr. Trainer.
Yeah, I had the same concern, I think, in terms of how do you identify or how do you track folks without you don't want to identify them and out them, if you will. So how do you track them through a system with multi points of entry and service? And I can see a survey being appropriate to try and gauge how serious it is. But the conclusions are a little nebulous. You've got to take it with a grain of salt in terms of, is it 85% or is it 65% or 33.5%? Whatever it is, it's good to try and gauge it, but it doesn't do anything for those people that aren't interacting with the system somewhere, whether it be the police or mental or health issues, one way or another. And so, trying to identify that, you have a tough job, and you gotta kind of squint at it rather than take it as
part of it. This is kind of a need prevalence, and again, based on survey methodology. Then there's the issue of demand, and then actual utilization. And so the utilization is the part where we can track how it actually is touching the system.
If some institutions, if the police or fire department or health department, hospitals, if they're interacting with people, they can relate, they can give people information or direct them to getting help. But if they're not interacting with that, if they're just out there living in the woods or camping here and there or at home with the lights out, whatever it is, it's hard to give them services that they could benefit.
And a little bit later, we'll touch on where we found people tend to touch the system. About 60% of the folks who are seeking mental health, behavioral health treatment who actually received it are through community mental health centers, clinics that are part of the public funded. It's the 40%, which tends to go into other settings, emergency rooms, health clinics, private physicians, absolutely.
Thank you, Mr. Chairman. So, some of this is caused by some sort of triggering event, like they had a negative, lost their job, death in the family, whatever it is. And so that's
potential, yes.
Yeah. All right, thank you.
So this is statewide. As part of our regional, actually this is maybe going back to Mr. Steele's question. So we looked at kind of there's the need versus how people are actually touching the system. So while we have this need, about 1 in 4 who may need it, it's considerably less that actually utilize the services. And that happens for a variety of reasons. Of the folks who may need some sort of intervention of some sort, they may not recognize that they have an issue. They may recognize they have an issue, but they choose not to do it, which, so there's kind of a wide range. Or they may actually, in this system where we're talking about the public system utilization, there may be people seeing private providers also. And so we kind of the range across substance use, serious mental illness, and then kind of that one. So looking at Anchorage, as we kind of broke down, we had, when we looked at those who needed some sort of alcohol or drug treatment, about 14% were identified. Actually, my apologies. I just realized I forgot. I had the slides.
That makes sense. Cheat sheet.
I'm trying to help you with keeping your eyesight.
There you go. I have corrected lenses. I should be wearing.
So roughly approximately 14% of the adults had some sort of need for substance use treatment. About 20% had any mental illness in the past year. So that's mild, moderate, and severe. When you looked at just a serious mental illness, 4.6%, moderate, 4.2%, mild. So these kind of generally match the overall state as well as what happens in we've been focusing on adults. We also tried to look at how the youth needs were out there.
Let me interrupt you for a second.
I'm sorry.
Jack, another question.
Thank you, Mr. Chairman. Yeah, no, the 1 in 4 stats is pretty alarming. Okay, but my question is, so do the stats go up in the wintertime?
Great question. Don't know that we necessarily address.
That would be something really important, I think, to find out, especially because the numbers are so high. And I think we all go through a little bit of something in the wintertime. Yeah.
Definitely some seasonal affective disorder and a little bit of cabin fever. We didn't specifically look at seasonality in our project, but definitely something that could probably be done. So.
Good, thank you, Chairman.
So looking at youth, it's a challenge, another challenging population, but just about 31% had some sort of substance use risk. That overall, about 17% had some moderate to high risk behaviors connected with substance use. Close to 30% had some sort of mental health issue in the past year. And then a little over 9% had some past year mental health issue and substance abuse kind of combined. Pardon me? What is youth? Youth is, in this I believe, is 9 through 17. And to a previous question about where they're accessing the system, this is statewide. The 60% tend to be served through the Division of Behavioral Health Treatment and Recovery providers, and physicians. Then the breakdown, as we mentioned just a little bit ago, comes through other kind of clinics, tribal health clinics, rural health clinics, physicians clinics, private providers, and so on. I would suspect that this is somewhat similar in Anchorage, but we don't know for sure because we weren't able to drill down that into that level of data at this point. Now, one one of the questions, the last one was kind of about where people are being served. This is also where one of the things we looked at is how do people shift around in the state. And so this slide addresses percentage of clients served in and outside of their home region. So if someone was from Anchorage, are they only being served in Anchorage? Or are they traveling to a different region for some sort of service? Or are they doing both? And kind of what we found was about 85% of the folks that were touching the system were served in Anchorage. There are some that were being served in other regions, and that we don't know exactly what treatment they were receiving, but for instance, it could be that seasonal jobs, and so they could be in Anchorage for 9 months of the year. Then during the summer, they are fishing community, and so they are traveling out and then receive services in Dillingham.
So maybe some double counting in some respects.
Some possibilities.
Services.
Yeah. This also could be someone who needed residential treatment services, and there wasn't one available in Anchorage, so they received services outside. So across Anchorage, comparatively to the different other regions, basically on the road system, there was a higher likelihood of you being served in your home region than anybody off the road system. Looking at this question just a little bit differently, is who are the providers serving? And here we had about 3/4, if we looked at Anchorage, 3/4 of the providers in Anchorage are serving Anchorage people, and that other quarter is coming from somewhere else. One of our partners in this project was the Mat-Su Health Foundation, and they were very, very interested in looking at the Mat-Su borough. In a lot of data things, technical things, Mat-Su gets lumped in with Anchorage as South Central. And because as they are expanding their community so large, they wanted to look at a breakdown, so they started to look at a breakdown. So this was a question of interest to them: are their citizens coming to Anchorage for treatment because it's not there? So the other just briefly touching is how is the system funded? Because that really gets at gaps as well. Is there adequate funding? And so through the state's Medicaid payments, if you look at this graph, on the far left is Anchorage as a region. And as you can see, Anchorage received, over the trend of this 5 years, it receives a large chunk of Medicaid payments for behavioral health related clients. When we look at publicly funded, we have Medicaid funding as well as grants. And so when you look at the treatment and recovery grants and substance use grants, we also see a similar thing. Anchorage tends to receive more of those funding, more of those monies than others.
Sorry to interrupt. Is it okay if I just to go back to the last slide, and just to say something about the fact that there hasn't been an increase of Medicaid payments really between 2011 and 2013. Is that because the reimbursement rate hasn't changed, or what?
I was actually going to head in that direction here in a second. Lisa was raising the fact that why has it basically been so stable and a number of things go into that. The reimbursement rates have not changed, and in fact, one of we talked about forces, and in here in a sec, I was going to talk about some work that's going on currently is rate adjustment. We're in the process of looking through rate adjustments for providers in the state. That has basically been flat for actually, I think, even earlier than our study too. So. Here in a little bit, we'll talk about some of the broad state reform activities that will probably end up trickling down into Anchorage as well. Actually, you had received, let's look this up here. You received some colorful maps. This was a way, courtesy of the Division of Behavioral Health, as they have been reporting to the legislature on their current services. I included this as kind of as context, just to show you kind of the current level of grant funding. Here, it's a series of 4 maps that look at treatment and recovery grant funding by region, total DBH grant funding, but in particular there's one on substance use disorder funding across the state by service area and program type. And to show some context, when you look at, again, when you look at the continuum of care, Anchorage tends to have a fuller continuum of care just by virtue of a large population and resources being there, and tends to receive more funding for that. And so there's a breakdown on some of the different things. The big circle, and I don't have this on the slides, but the big circle in the lower right corner is Anchorage, and it shows that the pie has a lot of different pieces that are covered. And then there's a map for prevention and early intervention grant. So this is current FY17 funding, grant funding that they are doing. The amounts will change through the course of this legislative season as there are cuts being made. But so we'll have to see where that goes by the end of the session. So this project, well, it was several years. As soon as we published it, in last year, it was already out of date. It's the way data goes and systems. We talked about forces of the system. The state is currently undergoing Medicaid reform. Well, they expanded Medicaid, and then there was also a significant push to do significant Medicaid healthcare reform. And so there are 16 initiatives that are going on at the state level. 14 of those initiatives involve some sort of behavioral health related work that's going on, ranging from primary care, addressing primary care, telemedicine, and so on. And there was one initiative that is behavioral health focused. That initiative currently is in process, and they're looking at redesigning the behavioral health system in Alaska, and that will have some rippling effects down to the communities of what's available and what's going to be funded. And it's, I want to say it's in the early stages, but it's maybe in the first quarter to third of their efforts. And so they're on some pretty tight deadlines, and hopefully in the nearer future, there will be some. One of the things that will come out of that, out of the overall healthcare reform, and that will impact behavioral health reform, is they are looking at administrative service organizations to oversee the payments and the service. And as that gets put in place, there will be an increased ability to track in closer to real time the actual use of the system and how people are being served. One of the findings we found from this was that one of the reasons why people really hadn't done this before, this kind of work, this project before, was because the infrastructure was not in place within the system to track. I mean, there are some limited tracking, but as a way of looking at a comprehensive picture, it wasn't there. And so they are, part of the reform activities are trying to put infrastructure in place to be able to track this and give us better real-time information as we go. So in taking this forward, this was really, especially in one, I don't know, I didn't see the handout here, Nancy, but there is a regional report that I think that is available if you didn't get it. That has even more information. I just kind of did the highlights that Jimbo talked about. In looking at the next steps, is there are some other sources of data that we used in here, but they've been updated. The behavioral risk factor surveillance system, the systems that are going to be put into place as the systems are reformed. There, at the state level, Alaska is part of the hospital discharge data network that reports federally. There's the potential to actually get some better information about behavioral health, substance use service here in Alaska as we get drilled down into that. As well as the Department of Labor, especially in terms of workforce capacity and development. I think are just some initial things right off the top of my head that will be able to help paint this picture a little bit clearer. I think in general, the system, the canoe graphic that we use is we're all in the same boat in terms of needing services. We all have our individual org, and we're not necessarily rowing in the same directions. And so part of the work that we're doing with the behavioral health system and healthcare reform is trying to get the paddles generally rowing in the same direction to address the big needs and priorities of the state. And I don't think I have any more highlights.
Questions for Mr. Weldon?
I just, so on this, I want to understand. So this is just money that comes from the Department of Behavioral Health.
Yes.
Correct? And this would be the total for Anchorage.
Yes.
And then you break it down into the 3 ones. Is there a duplication between these other users at all?
They should be.
I could sum the 3 pages
Yes.
together as total.
That's my understanding.
And so this is just, is this like federal money comes to the state plus some state money to funnel to us?
This could be some federal block grant money, but this is in large part general funds coming from the state. And that's why this is one of the key things is the budget gets cut. Some of it is durable now.
So, but the city puts in money too. So for this kind of purpose, house up, there's probably more money being spent. This is just state.
This is just state.
Good, thanks.
Because of the privacy restrictions, it would seem to me, and because of the either individuals' inability to give you accurate facts if it's drug treatment or mental health or whatever, it just seems to me it's awfully hard to track people if you don't have names, social security number, or something to eliminate double counting or, in fact, mistreatment of people because they may be going to multiple, certainly in Anchorage where there's multiple servers, they may be going, to different locations to get the service, and tracking them efficiently is probably a tough job.
Definitely a challenge. Earlier, I mean, there's definitely it's like how accurate it is, and duplicated versus unduplicated, and so on.
And consistent treatment.
And consistent treatment. Earlier, when I was talking about the sources that have actually the information that was protected healthcare, initially we came up with 8 million records, and it was through the deduplicating process. So trying to get that unduplicated count, we got rid of 2 million, and down to that 6 million. So it's definitely a challenge, but it's something that definitely takes some effort.
And it's tough to get a system. I mean, because of the privacy issues.
Now, the other piece that I didn't really talk about today was that we looked at though is we looked at the tribal behavioral health system and how the system, because it's really has developed into a separate system of care, even though they do serve non-tribal members in some communities. And what we found was that the state Medicaid information and the behavioral health AIMS service data is actually a fairly good approximation of who's being served and
Because they want to know where the money's going.
how it's being served in their system. There's still some that aren't picked up in that, but generally you can imagine trying to get information from 30 different organizations because there's no one central tribal health governmental entity that tracks the information like the state does with the Division of Behavioral Health.
Plus, if you don't know a name or number or something, tracking is virtually impossible. Thank you.
Any other questions? Thank you, Mr. Bold.
Thank you for your time.
Next item on the agenda is the Clip Roll project.
So having this larger picture view is in response to the question was raised after it's actually been a few meetings ago, questions around how easy is it to access treatment services. We had one of our nonprofit providers talk about a family member who overdosed and the tragedy that's happened in so many families. How easy is it to get to treatment? What's the availability in the community? Those are questions that we'll continue to discuss. Our committee is on homelessness, but homeless folks are a core piece of people who also need that access to treatment and services, and so it seems like this is a great committee for us to keep this topic under discussion. It's also a piece of that infrastructure that we've talked about for the community plan, paying attention to the treatment needs and the needs that people have in order for us to make that episode of homelessness as short as possible. We need to get people out to treatment and then back to community. So the next meeting in April, we've suggested using that meeting to help us with additional data collection around treatment needs for the community. If you think about looking at the prevalence data and the surveying information that Mike's just presented that's going on at the state, and then bringing it down to regions in a process that we're using to get a better handle on what types of services are needed in Anchorage. We're partnering with the Matsu Health Foundation as they go through a similar assessment of treatment needs in their region. There is a lot of mobility between Anchorage and Matsu in terms of accessing services. So last month, the Matsu Health Foundation held a community forum where they convened their treatment providers. They conducted a survey of those treatment providers asking about the demand for services, what types of services they're providing, in an effort to get a broader view of all of the services happening in their region. So we asked them, I think kind of smartly, we asked them, can we just use your survey? Can we distill all your materials and replicate that in Anchorage? They have agreed to do that, and in addition, will be coming into town next month to help us facilitate that time with our providers. So on the 19th, we'd like to shorten the assembly meeting and to have a forum with treatment providers between 12 and 4:30 with Matsu Health Foundation joining us and asking the questions that will get us to how many folks are getting served in our community and what array of services are all of our providers giving in the community, which will help us then, as one of the data points, bring it from the larger picture prevalence data and assessment, asking providers what they're doing and what they would like to, what they see the need for continuing to do, and then helping us inform what we might do to increase the infrastructure that's needed for people to access treatment. And the one project that brings that into focus for us is the Clitheroe facility that really needs to be rebuilt.
Ms. Gray-Jackson.
Thank you, Mr. Chairman. Thank you, Ms. Burke. Did I hear you say that on the 19th you'd like to shorten the assembly meeting? Did I hear you say that? Or did I?
The committee, I'm sorry.
Okay, yeah.
I'm sorry.
Thank you for the
I think of you as the assembly, yes,
Thank
this
you.
committee.
Thank you, Mr. Chairman.
I have absolutely no control over the assembly.
Mr. Crane.
And what we'd like to have is, if this works out, we'd like a dollar figure on how much it would cost Because I'm more than willing to bring back a subsidized tax on alcohol and other substances, because we can target money in like the state. We can target specifically towards a control center. So let's go exactly how much money we're talking about. So when I look at what Michael gave us, we've got a huge need out there, and we're not spending our money smarter, not getting enough money. Because substance abuse is a problem. There's just not the beds. I think last time I heard it was 14 beds in Anchorage, which is crazy for a town this size.
Right.
So
Yes.
give us numbers so we can start to work with that. Thank you.
Excellent. Yeah, the project, and this is where I really promised Salvation Army, our partners at Salvation Army, that I won't describe their project as being dilapidated or falling down. The building that they are in is definitely needs rebuilt. But as Mike was pointing out, there's changing substances. That means changing methodologies. That means different types of detox, getting to treatment. And so I feel like we've done with our homeless service system, we need to track it all the way from when we identify a person having a treatment need, all the way through they've received treatment and they're stabilized in the community. That kind of assessment needs to happen through the community, which would help us get to how much infrastructure do we need to build around that. So we hope to use the statewide information that the trust has been gathering, bringing that down to the region, partnering with Metsu. We also think it will be wise to target those places where utilization is increased because of substances. So our own fire department call-outs, the hospitals, any of those kind of resources. We plan to ask those partners to be with us as we plan through this. And then looking at the pressure points, where do we see people falling out of their homes into the homeless system? Combining all of that information should help us get a handle on rebuild of the Clitheroe project. As we're doing that assessment and planning process, we have a pre-development grant to go and look at the site where Clitheroe is, so that we will have a better understanding of the type of footprint that we might use if we were to rebuild or make more services available in that location. There's a contractor on right now, Steve Fishback, who is working through the 4 Acres pre-development program, assisting us in looking at those pre-development. As soon as the ground thaws, we'll be able to get some soil tests and some of that engineering done. And so as we move forward, gathering all this data and collating it, we'll also have some more information about our site.
Mr. Steele?
Is the property out at the airport, is that airport land? Is that municipal land? Is it a combination of, what is it?
It's 30,
right there around
30 acres of municipal land, and it is adjacent to the airport property, but since they've settled on the runway that will not impact that portion of the airport, we're good to go. However, we do have some infrastructure problems out there. There has to be a utility water connection run to that site, which will be part of the factoring of our analysis.
Part of the upgrade.
Will that upgrade outweigh the benefits of the site in itself?
Now that recycled zone that was out there, was that on municipal property?
Yes.
Is that the portion?
Yes. And that has been almost completely remediated. There's one section that's under investigation right now with a federal grant to look at contamination. Yeah, but it seems as though that site that's pretty well defined and manageable. So after the 18th, we will be able to, by then for sure, we'll be able to be out there looking at soils, and then we'll have additional information to bring back to the committee over the summer. And we'll hopefully get to those numbers assembling their training.
Thank you, Madam.
Okay.
That's any other questions?
Well, that's exciting.
Well, actually, just before we move on, since Ms. Burke mentioned the April 19th meeting of this committee as being impacted on that, because we'll have a new assembly by April 19th, we'll have a new chair and members of this committee. Ms. Burke has suggested, and I think it's a good idea, that she's developed the next 2 months, agendas for this committee,
so that whoever gets put in charge will have a running start. There'll already be agendas developed. They won't have to start from scratch the first week. I just think it's a good idea for whoever becomes chair of the assembly and chair of this committee that will be available going forward.
You can still participate. You know,
Absolutely. But Ms. Burke will have that in coordination with Amanda and Sierra. So whoever gets this position will have some transition taken care of. Good idea.
Okay.
Next topic.
Our backbone partners are in transit today, but I think there was a topic raised during Mike's presentation that is one that's foremost on our mind, is connecting in a meaningful way, both around the treatment that we just discussed, but also around homeless service delivery with our partners in the tribal system. And we've done some work with United Way and the Homeless Coalition following up the resolution that AFN passed last year around homelessness to find how we might meaningfully partner with them around this initiative and the work that's happening broadly in Anchorage. And there are a couple of more meetings on the calendar later this month to follow that up, because everyone agrees there's a role, there's a way for us to be stronger partners with the tribal system, and they're actually very interested and willing to kick off those conversations. I really think the work that we've done around having the data, we're able to tell how many homeless individuals are from each region. People identify regional corporation affiliation. And so we're able to get data back to our tribal partners, and we're also able to articulate strategies that make partnership meaningful, and I think in some ways easy. And so those conversations are going forward. I'm feeling really encouraged by that. Particularly when we think about ways of billing for treatment services, if we can get the right tribal partner to partner with us, we could have a billing scenario that increases resources greatly for people. So gluing in our tribal partners over the next few months is going to be very high priority. And then looking toward the community, not only around the substance use treatment services, but also doing some broader analysis of our case management ratios, the staffing ratios across the entire continuum of homeless services will also help us with advocacy. We're anticipating needing to advocate around access to particularly mental health services. We feel that the mental health system is very strained right now. Case management ratios are very high in those areas, and it really is one of the frequently discussed budget items for reductions in the state budget system. So we are creating advocacy and information for our nonprofits to carry back to their legislators around how potential cuts could really negatively impact us in this community. So those are our...
Dominic, questions here. Going back a little bit, the 14 beds that you said we had in Anchorage, are those all is that the locations? Oh, okay. And does the Native Health, the hospital out there, do their health services, do they have any treatment at that location? Are there any beds there? And they're included?
So what's happening with that is there are the Ernie Turner Center located at Elmore and Tudor has been for some time our detox provider, and this is an important distinction, that when a person has substances that could be life-threatening, they detox and then they transition to treatment. And it's an important thing that we start saying detox and treatment in the next breath, because if we detox someone and they just go back to street, actually detoxing, serially detoxing can be more damaging than just staying undetoxed. I mean, in some ways. That's not a very elegant way to say it, but I think you get what I'm saying. Like, we have to have this continuum. We have to be able to let people access detox and then go to a treatment bed, and then probably you would predict my saying next, then to sober housing, then out to housing, so that we don't have any return to that high level of need. So we will be mapping out that entire continuum. But previously, that Ernie Turner Center was the only place we had for detox in the community. And that has recently transitioned over to South Central Foundation, who is the part of the hospital, operates the hospital. And so that's a medical service that will continue to be a resource for the community. And then what we hope to do with this planning process is then map out how many people, if we had access to treatment beds right from there, what's the right number of each of those levels of care, detox, treatment, and then housing. So that will be the product that we hope to come out of this planning process as we move forward.
One more question. The facility on Fireweed, where folks, I think, they come in to get services, if you will, on an outpatient basis. What exactly is that they're doing? Is it maintenance?
The deal exchange is there on Fireweed.
Is that what it is?
It's a deal exchange.
Okay. So that's just users that are trying to keep it.
Right. So you could roughly, probably, I'll think of how to do this pictorially for you. We could talk about the low, medium, high level of need, where someone with a very high level of need is going to go into certain levels of inpatient treatment, and then outpatient treatment frequently follows that, where you continue to go, but it's more like after hours meetings, where you continue this process of recovery. And then that can go into informal community supports, such as AA, to help you maintain you keep it going. So that's one of the things that we definitely will be doing, is mapping where those resources are, and then trying to get the data, the prevalence data, to map over that to help us know how many units of inpatient treatment do we need, how many outpatient slots do we need,
and where's the demand?
Right. And then what's the distribution across the city? Is it easy for people to get to? Is it on one of the new bus routes? Sure. We can start using GIS mapping, in fact, to help us to look at that, to really to make sure that we're helping the sector be thoughtful about where they're
and all this takes money.
Well, in the
volunteer.
Of course it will, I think, because our demand outstrips what's available. Yeah. But I have been excited about how much we've been able to do better with what we already have in the homeless system, just by coordinating and overlaying this sort of structure. So I guess I would say maybe not immediately. We don't need money. We first need to know what we don't know, and then we'll ask about money.
And maintaining the partnership.
Because we have another committee meeting immediately after this, so we'll have to wrap this up. So I want to make sure there's time. Is there anything else?
That's it, thank you.
Any member comments? Great, Jeff.
Thank you, Mr. Chairman. You mentioned the fact that this is your last meeting, and it's mine too. And I just wanted to take the opportunity to thank you for doing a really fine job as the chair of this committee, and hopefully that whoever takes your place and fills your shoes, which is not really typical, continues in the same manner that you have. I'd like to give you
Thank you very much.
Just leave the shoes, we can fill them.
Yeah, I wear size 12, It's got to be physical.
I wear size 12 too.
Well, 10 men's. Okay.
We have. I know Ron's anxious to make comments, but okay. We have, but we have to keep them real quick, like 30 seconds. So
last time it was a minute. The church gave me a minute.
It's inflation.
Oh, hey, applauded that good meeting. Hey, first thing, make sure you get a copy of my letter. It's only getting worse. I am going to file a suit against the city for inverse condemnation, because you've overburdened the neighborhood so substantially without buying us out that I'm going for economic damages. And anyone who participates in this is subject to subpoena. What you've done here is going backwards. And I just mentioned to Lisa that they're shipping in via the bus, published in the Catholic Anchor, their surplus homeless are burdening Anchorage. So that's a terrible situation that's occurring. And then the other thing, I hope you read both letters, because it's been over 9 months and I haven't heard from anyone, and my personal appearances. So running for District 4, when I put my ear to the ground, there's going to be such a revolution and a rebellion that this is going to be a clean sweep, and these programs are going to get flushed down the toilet, and some of them belong there. And as far as being Alfred B. Newman, I'm not. I'm Ron Oleva, and I have a letter that says I'm safe, so you can include me in that 75%. Quickly, the anger management I tried to get, I called Susan Bombolonsky because she's now a counselor. Left a message with the receptionist, left a message on her cell phone, left a message on her office phone. She didn't return the call.
Did you get mad?
No, I didn't get mad because that's the BS that goes on, and you guys are seeing it to the choir. Hey.
Thanks, Ron.
Hate to see you go there.
Thanks. Appreciate it.
Yeah.
Any other comments? Real quick. Seeing none, we are adjourned.